Bismillahirrahmanirrahim. Today we will have case quiz number 41. Case data: 42 years old female presented with bilateral knee pain, limited range of motion and swelling of 8 years duration of intermittent course followed by both hands in additive manner. The onset was not associated with fever nor rash nor morning stiffness. Bilateral sticky nasal discharge of 1 month duration with nasal obstruction of the same duration. She was diagnosed by an orthopedic surgeon as rheumatoid arthritis and received methotrexate and steroid in the form of dexamethasone for 1 year. However, shortly after the beginning of this treatment, the patient noticed itchy berberic skin eruption on the face, trunk, upper and lower limbs, and back of progressive course, followed by nodules of the same duration. On examination, she had mild tenderness of BIBs and MTBs. Neurological examination was free. Skin eruption was bilateral symmetrical erythematous macules on the face, trunk, extensor surface of the upper limb, lower limb, associated with glistic nodules of the same distribution. Nasal exam showed thickening of the nasal septum. The investigation showed high ESR, SGBT and creatinine were normal, CBC with differential was normal, urine analysis was normal, rheumatoid factor was positive with titr 260. ANA was negative by both ELISA and IF. And finally, plain X-ray of the hand showed periarticular osteoporosis and osteoarthritic changes. So, what is the diagnosis? The answer is yes. Remember that this case has worsened with steroid. It has very long-standing, poorly controlled with treatment, but without deformities and the pattern of skin eruption. So this case is libromatous leprosy. Leprosy is a chronic infection primarily affecting peripheral nerves and secondary affecting skin, mucous membrane, reticular endothelial tissues, eye, brain, and testes, caused by Mycobacterium lepra, which is alcohol-fast bacillus stained with the Nielsen stain. The nasal discharge is the main method of infection, followed by exudate from ulcerated skin, saliva, milk, semen, and feces. It is a highly infectious organism of low pathogenicity, so subclinical infection is common, with very long incubation period may reach up to 7 years. The clinical types of leprosy is subclinical, intermediate, tuberculoid, with borderline tuberculoid as a subgroup, mid-border or midline, with borderline libromatous, and finally libromatous leprosy. We will discuss only tuberculoid and libromatous leprosy. The tuberculoid leprosy mainly affect nerves with limited skin affection, presented with pain, thickening, glove and stock hypothesia, and muscle atrophy, mainly in the ulnar, sural, and great auricular nerves. The libromatous leprosy, it is presented with mainly with skin and nerves also. So the skin shows macules, papules, nodules, which are bilateral, symmetrical on face, trunk, arms, and legs. The macules are erythematous, numerous, with vague edges and loss of sensation and hair growth. Papules are glistening, erythematous, and gives leonine facies, which is the face of lion. Nerve damage occurs late in this case and is bilateral and symmetrical. Nasal stiffness, discharge, nodules, and ulcerations of the septum with cartilage destruction may occur. And finally, thank you very much for your attendance, and we will see you tomorrow with case quiz number 42. Wassalamu alaikum wa rahmatullahi wa barakatuh.